82-year-old female with systemic hypertension, hepatic diffusion HCV+, with evidence of severe aortic stenosis, aortic valve area of 0.4 cm squared, with a maximum transaortic gradient of 84 mm of mercury, and dilation of the ascending aorta and aortic arch. The procedure consisted of the following steps: aortic valve replacement with the stentless biological prostheses Edwards Life Science number 23 with the so-called inclusion technique. Replacement of the ascending aorta and the aortic arch with the debranching of the anonymous trunk and the left common carotid artery with the Vascutech Lumpia number 28 vascular graft. This is the aortic angiography, with a clear involvement of the ascending aorta and aortic arch. Shown are the anonymous trunk and the left common carotid artery. Proceed with the isolation of the right axillary artery. A tobacco pouch is prepared. The direct cannulation of the artery should be performed with the Scheldinger technique. The dilator helps to introduce the perfusion cannula. Cardiopulmonary bypass begins. Aortic cross-clamping infusion of the retrograde cardioplegia. Resection of the ascending aorta and of the aortic valve. Decalcification of the aortic annulus and implementation of the stentless aortic valve Edward Prima Plus with the inclusion technique. Re-implementation of the coronary ostia, first the left, and then the right. Preparation of the vascular graft Lumpia Vascutech number 28. Preparation of the proximal anastomosis, taking care with the orientation of the vascular graft towards the superior aortic trunk. Once the body temperature reaches 26 degrees Celsius, the patient is ready for circulatory arrest. Proceed with the cannulation of the vascular graft and with the preparation of the selective anterior-grade cerebral perfusion cannulas. The anonymous trunk is then cross-clamped, maintaining the flow of 8 ml per kilogram per minute into the right carotid artery. With the circulatory arrest started, surgical preparation of the epi-aortic vessel, anterior-grade perfusion of the left common carotid artery with a flow rate of 5 ml per kilogram per minute. The perfusion should be monitored and maintained at around 60 to 70 milliliters of mercury. The preparation of the aortic arch is now completed. The restriction stops approximately 1 cm proximal to the origin of the left subclavian artery. A vacuum vent line is inserted through a branch of the vascular graft in order to keep the operating area bloodless. A distal anastomosis between the vascular graft and the aorta is performed through a 3-0 polypropylene suture interposting a Teflon strip. The anastomosis is completed by draining the chamber of the heart. Then the systemic perfusion is restored, and the aorta is subsequently declamped. The anterior grade cerebral perfusion is still running. Once the preparation of the epi-aortic vessel is completed, proceed with the anonymous trunk debranching, paying attention to the correct orientation, using a 4-0 polypropylene continuous suture. Stop the cerebral perfusion. Control the backflow from the left common carotid artery. Pre-preparation and implementation of the anastomosis using 5-0 polypropylene continuous suture. Blood flow meter control of the left carotid artery and the anonymous trunk. The final results. The aortic cross-clamping took 84 minutes, cardiopulmonary bypass took 171 minutes, anterior grade selective cerebral perfusion took 32 minutes, and circulatory arrest took 17 minutes. The post-operative course had no complications. The hospitalization was 8 days. The post-operative CT scan shows the success of the procedure. From December 2007 to October 2011, 36 patients underwent debranching procedure at our unit. Indications for surgery: chronic aortic aneurysm in 13 patients, acute type A aortic dissection in 16 patients, intramural hematoma in 3 patients, residual aortic dissection in 4 patients. Related procedures: ascending aortic replacement in 36 patients, biological Bentel procedure in 26 patients, coronary bypass grafting in 3 patients, the frozen elephant trunk in 3 patients, mitral valve repair in 1 patient, mitral valve replacement in 1 patient, distal reintervention procedure with endovascular TEVAR in 3 patients. In 21 patients, we used the Lumpia vascular graft from Vascutech. In 2 patients, the GPE FlowWeave Plus graft from Yotech. Homemade vascular grafts in 13 patients, and in 2 cases, the Jotech Evita Plus stent graft was implanted. The average CPB time was 177 minutes, aortic clamping took 104 minutes, circulatory arrest took 30 minutes, and 52 minutes for cerebral perfusion. We had a mortality rate of 16%, a stroke in 1 patient, a temporary confusional state in 3 patients, and temporary renal failure in 2 patients. The average hospital stay was 15 days. We believe that this procedure is easy, safe, and provides excellent control for the anastomosis. This is our patients 3 months after the procedure.